Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to attempt to talk towards the biopsychosocial model in osteopathic manual practice and the limited utility that it has. Now, I was inspired to bring this concept back to the front of mind because I was perusing the International Journal of Osteopathic Medicine, and there's an article that is in press at the moment, and this is July 2nd of 2024. And the article was a survey of New Zealand osteopathic manual practitioners with respect to, I believe, attitudes, generally speaking, towards biopsychosocial model. And there was a 3-category thematic analysis, and there was those that were BPS, biopsychosocial, open, resistant, and there's another category. That doesn't necessarily matter for what I'm going to attempt to do. What matters is that we note a few things. So we're going to touch on ontology, or the theory of what is real, or the study of reality. In science, really, you're talking about a classification system, so varying constructs by which you will describe each thing in its own right, so that you can then compare and contrast against things that you describe in that category in their own right. The other thing that we'll have to talk about is epistemology, or a theory of knowledge, a theory of truth, that is contingent upon the ontological viewpoint. Ontology, you generally have those who believe that the forms or the Platonic concepts or ideas are the most real, and then you have those who believe that materials are the most real, the materialists, or there's another term that I'm looking for. It's not quite going to work. But anyways, those that believe that ideas are the most real are much more subjective, and those that believe that objects are more real are more objective. Anyways, osteopathic manual practice, manual, is what is performed over the vast majority of the world that is not the United States of America. America has doctors of osteopathy. They are trained in America, they work in America, they have unlimited medical licenses, just the same as medical doctors or MDs. Everywhere else in the world, osteopathy must be argued meaningfully to be a positivist approach. Positivism is an epistemology. It puts forward that there is an identifiable singular reality that is observable with appropriate experimentation, and usually the observer is the challenge. So the criticism is that you're trying to have the impartial observer, or the observer from nowhere. Whereas subjectivists or constructivists, constructivism is an epistemology. So hold on a minute. Positivism is an epistemology that is built much more on the objective side, or on those that believe materials are the most real things, material objects. Whereas constructivism is built on much more a subjective framework and suggests that ideas are the most real thing. Okay, so the biopsychosocial model comes from, or at least is primarily attributed to, George Engel. I believe it's George Engel. There was a paper in 1977 that Engel put forward, and then he put forward a paper in 1980 that was attempting to explain how to use the biopsychosocial model through sort of a vignette of chest pain, a patient with chest pain, and essentially suggesting that, and this is my recollection, I may be incorrect on some of the details here, essentially suggesting that how the practitioner interfaced with the person with chest pain precipitated some of the other stuff. Anyways, so the biopsychosocial model is in response or in conversation to what is termed the biomedical model. The biomedical model is accused of heavy reductionism, reducing things to biological or really physiological processes. Whereas the biopsychosocial model is attempting to be more holistic and speak to those ways in which you can import, or not import, but pay more attention to the other elements. Now, the biopsychosocial model is a model. It is not a hypothesis. It is not a theory. It is a model. Models have normal problems. They are only able to do very predictable things with input. They're only able to accept certain types of input. This is one of the reasons why when you hear modeling data, if it doesn't have all of the factors that reality includes, They can only be close to correct at best and far from correct as the norm. So depending on what variables you're able to feed into your model, you can only come up with certain types of answers. So the biopsychosocial model is less described as having clinical utility as it is described, or could be described, or I would argue it is better described as an ontological classification system. There are three categories that are distinct from one another, but co-occur in every individual seeking healthcare that you will find. There are biological components, psychological components, and social components. To be fair, the psychological and social probably meld into one another more than the biological will meld into the other. So you can argue as constructs whether or not psychological and social should be separate or they should be together. But that's a different conversation that may not have a lot of use here. It's a model that, for Engel, the aim was to put a little bit more focus on the psychological and social aspects of patient presentation. If I remember correctly, Engel was a gastroenterologist who happened to be very interested in the other portions of the presentations, and that's probably from clinical experience. The term biopsychosocial, I believe, is more accurately initially attributed to somebody named Roy Grinker in the 40s or 50s, the 1940s or 1950s. So there is a history of it prior to Engel, but Engel is the one that most people will point to as being maybe the guide or the progenitor or the director of the biopsychosocial model, whatever you like to say. But the biopsychosocial model definitely is speaking more to the subjective experience of the patient, how they experience the disease, how they experience healthcare, their subjective interface with these things. Whereas osteopathy, as already noted, is much more accurately described as positivist. The practice of osteopathy includes the requirement that you're going to identify motion restriction, interface with motion restriction in a predictable set of ways that is going to be respectful of the barrier concept, which means, or I would describe as, don't make the patient say ouch. That is including the subjective experience of the patient, because the patient may say ouch or may show resistance to movement because they feel subjectively that they need to protect themselves. So the barrier concept includes more of that soft side, more of that subjective experience side of treatment already in osteopathy. Which is one of the reasons I would argue that the biopsychosocial model is moot in osteopathy. Then after you've applied treatment that doesn't make them say ouch, you reassess in a valid, reliable way, and either it changed the movement restriction that you found or it did not, right? So you have to be able to find, is it moving or is it not? If it is not moving, as would be expected or in comparison to its paired structure, then you interface with it in a way that is guided by the barrier concept, which is patient-centered, which is responsive to the subjective experience of the patient, especially if you encourage the patient to communicate if they feel like they need to protect themselves, short of a very obvious pain response in the form of audible noises, visible faces, or palpatory or palpable changes in muscle tone or active muscle tone. And then you reassess with the same methods and it either changed or it didn't. The biopsychosocial model is subjective. Osteopathy is objective. Now, within the profession of osteopathy, there is evidence to suggest that the professionals prefer to measure the value of their work or the impact of their work on the patient experience, which is understandable in relation to the barrier concept being central. But it's not understandable because it's either moving better or it's not moving better. Osteopathy is positivist. Osteopathy is not subjective, but it does include space in the decision-making and the actual physical application of the skill set for the subjective. That's the barrier concept. The biopsychosocial model in medical practice, in healthcare practice, essentially gives you the opportunity to use very broad buckets to figure out whether or not something is amenable to physical intervention or not amenable to physical intervention, or how amenable it is. So if, as an osteopathic practitioner, you identify a motion restriction, you now know that at least on some level, there is room for some physical intervention, some hands-on intervention. If you perform that intervention in a way that is sensitive to the patient as guided by the barrier concept, and it changes, then you know that there is something biological that is amenable to your treatment. You may learn after that, based on subjective presentation, that it didn't do what is required to change the subjective presentation. That then lets you know that in concert with the physical presentation or the biological presentation, that there is psychological and emotional elements that you're not going to touch. Though you now know, if you found the motion restriction changed, the patient didn't say ouch, you did your job right, and again, the motion changed, they're amenable to physical treatment. But subjectively, they may tell you that nothing changed. That now means that there is some requirement for psychological and emotional care, which as an osteopathic manual practitioner, you are not properly trained in, unless you're a DO, and you may be minimally trained in that, or you may specialize in that, but you're minimally trained in psychological and emotional intervention. In most jurisdictions, you have essentially no legal right for psychological and emotional intervention unless you have other training previous to being an osteopathic manual practitioner. That's important to know because your skill set is physical, and you can identify when your skill set has done what it's supposed to do, but it didn't do what the patient wanted it to do. So the biopsychosocial model does nothing for how you practice osteopathy. It does something for you to be able to use a framework, very loose framework, a very broad framework, a very non-specific framework, to figure out whether or not your intervention is likely to help or unlikely to help on the patient's scale. So the patient has a subjective scale and an objective scale. Osteopathic practitioners work on the objective scale, whether or not they buy it, whether or not the culture supports that. Osteopathy contains, in its concept and its philosophy, which I'm not necessarily the biggest fan of because it's a fallback position, philosophy in osteopathic texts that I've referred to before can be defined as essentially thinking without the requirement of evidence. Okay? That's a general definition of philosophy, but it is noted. It's not Foundations of Osteopathic Medicine. It's, I think, an approach to osteopathic diagnosis and treatment. I think that's the one that I've referenced. I may be wrong about that. But anyways, philosophically, osteopathy contains the triune. A lot of healthcare practices contain the triune, mind, body, spirit, and it'll change here left or right, word for this word, that word, doesn't matter. A lot of healthcare practices have a triune. Osteopathy contains that, has a cultural preference for subjective measurement, but it is practiced. If you have the view of behavior, it is practiced in the physical realm. It's a physical skill set. The biopsychosocial model does nothing for that physical skill set. The biopsychosocial model in no way replaces the actual skill behavior, or the skill-based behavior that is dictated by the barrier concept. The barrier concept is sensitive to the patient's subjective experience, especially if, as I noted, you encourage the patient to tell you, if you feel the need to protect yourself, you feel the need to pull away, let me know. I want to back off on your behalf. So while the subjective experience is important in osteopathy, it is not the actual practice of osteopathy. The biopsychosocial model shows within the culture of osteopathy, or the presence, rather, of the attempt to utilize the biopsychosocial approach in osteopathy shows to me, in my interpretation, so you can point at me and say this is subjective, and I will understand that with respect to my interpretation of the barrier concept includes the psychological element, the subjective element of patient interface or client interface, whatever term you prefer in your jurisdiction, that makes osteopathy very specifically patient-centered, unless you as an individual have the concept that there are the subdivided categories in osteopathy: strain, counter-strain, facilitated positional release, cranial, visceral, whatever. And you're like, oh, this patient needs this approach, this patient needs that approach. That's not patient-centered, that's idea-centered, that's ideologically motivated, and it's inappropriate. The general framework of osteopathy does not require those subdivisions. It doesn't require those technique systems. It is a really good decision-making framework already that is poorly described and very poorly taught in my experience. So again, you can point at me and say that's subjective. What I just said is subjective because I don't have all the data. I can't. But I recognize that. In not having all the data, I can make the best statement that I can make with the data that I do have. Osteopathy already includes that subjective element in the barrier concept, whereas it gains nothing from the biopsychosocial model. The biopsychosocial model essentially is just advocacy to not focus only on the biological processes and focus on how the patient is experiencing things, how the practitioner is interfacing with the patient, and how the patient is experiencing that. So whether it's the symptom or the interface, it's simply saying, pay attention to that at a fundamental level. There may be much more development on top of that people would like to nitpick about, which I understand. I nitpick about a lot of stuff. I'm okay with the presentation of nitpicking, but the fundamental concept of the biopsychosocial model adds nothing to the profession of osteopathy. It adds nothing to the practice of osteopathy that wasn't already there. It may be something that has value for osteopathic research that is housed within the university system in sort of a publish or perish system, right? If you want to get a promotion, if you want to keep your job, publish something or else beat it. So you're talking about countries such as Australia, New Zealand, and England, or maybe the UK writ large is a better way to say that. So sometimes you just find stuff to do research about, but using the biopsychosocial model assumes that the biopsychosocial model does something for osteopathy. And my argument is that it does nothing. First, osteopathy in its actual application of skill, both diagnostically and as an interface, is physical, but it does acknowledge, due to the barrier concept, and you can find this in very early writing. So the first osteopathic book was Barber. It was E.D. Barber's book, and it talks about, just trying to secure relaxation. It talks about a lot about securing relaxation. Dr. Still makes mention of trying to make sure that the patient is relaxed. You relaxed or you loosen the articulation at both ends. If you look to, I believe it's 1917, Dane Tasker, the principles of osteopathy: don't hurt the patient, don't hurt the patient, don't hurt the patient, and don't hurt the patient. Very early on, you can see a insistence and a concept of paying attention to the patient and how they're responding to what you're doing. The barrier concept comes later, and the barrier concept, I do believe, is very poorly explained and applied writ large in the profession, because the barrier concept allows for a simple choice. Go into the direction of restriction, as long as they don't say ouch, and if they do say ouch, you make all the soft tissue soft, and that's indirect. Right? So you have a choice matrix there that is central to the patient, that is based on the subjective experience and presentation of the patient, but you have to encourage them to talk. You can't necessarily just visually, auditorily, or palpably identify when the patient isn't relaxed, because it may come on slow and the apprehension may not necessarily be expressed in a way that you pick up. So writ large, the things that we're trying to juggle here, that I'm trying to juggle rather, are that we have the biopsychosocial model, which is essentially a subjective constructivist approach, and we have osteopathy in its practice, which is a physical positivist-based approach. But osteopathy includes subjective measurements, which are predicated upon the barrier concept. Osteopathy is already patient-centered. It doesn't need another concept to infiltrate, to guide this. Teaching the biopsychosocial model does nothing for the physical intervention. It does nothing for the physical diagnostic. It does let you know, as I already sort of alluded to, when you've come to the edge of your skill set, so that your skill set, that physical skill set, is not going to do anything or what the patient desires. So if you find some form of physical restriction, you treat appropriately, the patient doesn't say ouch, and there's no change, okay, that means it's not amenable to that physical intervention. Now, sometimes it may take multiple attempts and multiple treatments to figure that out for sure. It can be a slow process. But then you have, on the other hand, you could have this matrix. So let's put forth a conceptual matrix that will help, I think, a lot of people. You get change physically, and you get change on symptoms. So things move better, the patient says, that's awesome, I feel better. That's one. You get the patient moving better, they feel no better, right? So they do move better, but they don't feel better. So the objective and subjective don't match. So if they move better and they feel better subjectively, they move better and they report feeling better, then the sign, the moving, improves, and the symptom, the feeling, improves. If you have the sign, so they move better, and the symptom, they report not feeling better, they now don't match. So the objective and the subjective match. So on the first one, the subjective and the objective match. On the second one, the subjective and the objective don't match. You could also have the person does not move better, so the objective has not gone in the direction desired, but the subjective, they report feeling better, right? So now objective and subjective don't match again, but it's more positive subjectively. You could also have they don't move better and they don't feel better. So now the objective and the subjective match, but not in a positive direction. That's all possible with osteopathic treatment. The biological sphere, the biological construct, is really the one that's going to be on the objective side, whereas the psychological and social constructs or spheres are the subjective side. So in the matrix that I put forth, when it moves better and it feels better, you've kind of got it all, right? That's fantastic. When it moves better and they don't feel better, you now know that referring to another professional is probably going to have more mileage for that patient. They're not amenable to symptom change from osteopathy or for a hands-on manual intervention. If they move no better, right, and they feel better, you may be hitting on something where they have a net positive outcome, but it's not necessarily because of the osteopathic approach or the physical approach. It's more so because the general environment and the interface with some sort of healthcare professional does something good for them. When it doesn't move better and they don't feel better, well, that's definitely when it lands more in the psychological and social spheres. So the biopsychosocial model adds nothing to the actual physical practice or skill set of osteopathy, but it does provide a framework in which you can interpret and figure out if you need to refer. But the simple matrix that I put forward also does that and doesn't require the biopsychosocial model. It doesn't necessarily add anything, as I've said many times, to osteopathic manual practice. Osteopathic manual practice already has all of the elements that are required to appropriately respond subjectively to the individual in the barrier concept, as well as recognizing through appropriate diagnostic approaches whether or not they're amenable to physical treatment and whether or not the physical and the subjective or the sign and the symptom match up properly. So if we look at find it, fix it, leave it alone, nature will kindly take care of the rest, as attributed to Dr. Still as a concept, not necessarily a direct quote, depending on how you look through osteopathic literature historically. He still never wrote it down, but that quote is attributed to him. Find the physical, interface with the physical, change the physical. If after you've done that appropriately, the physical has changed and or say the sign has changed and the symptom has changed, that's fantastic. That's proper union. Sometimes the sign has not changed and the symptom has changed. That's a nice accident. Sometimes the sign has changed and the physical has not. That's when the biopsychosocial model has some limited utility. Refer out. When the physical or when the sign has not changed and the symptom has not changed, again, refer out. So the biopsychosocial model adds nothing that wasn't already there within osteopathic practice. And it's essentially attempting to import more constructivism into the profession. So as a research program and a teaching program or a concept to teach within the profession, I would argue that it adds nothing. I would argue that better understanding in the way that I'm describing of the fundamental osteopathic concept will allow for opening up on detail in an appropriate way that is sensitive to how the profession is practiced physically as a skill set would be more appropriate. So the simple matrix that I put forth, sign and symptom either match or they don't match, and you now know either they're amenable to the treatment, both objectively and subjectively, they're amenable objectively but not subjectively, and then the other way around, you can now figure that out and whether or not you need to refer. So again, my motivation is to simply note that the attempt to import the biopsychosocial model adds nothing to the profession. The profession has subjective elements already that are appropriate if taught appropriately, that are not going to receive any more or less with respect to the biopsychosocial model. The biopsychosocial model is very general. It's a categorization system. It's not a, it doesn't tell you what to do. It just tells you where the problem might live, right? So hopefully you've gained something from that. Hopefully you are learning something and it is of value to you. And I look forward to speaking with you again.